Okay, I see that it is basically 2 minutes after the hour. Thank you, everybody, for joining. This is an increasingly common occurrence, these virtual town halls. It's started off about 6 months ago with it being a new experience for most of us. However, today it's a good opportunity to understand why we're having to do all this remotely. I'm Richard Griffiths. I'm with the Georgia First Amendment Foundation. I'm going to do my best to be your moderator and your host, the Zoom tech for this session. Any screw-ups here are mine and none of the organizers. A few housekeeping things. Unless you're a panelist, I would ask that you turn off your video. Town hall participants can then choose to see only the speakers, which should make it easier to follow the discussion. I'm going to be sharing quite a few data screens, so keeping the number of videos down will make it easier for you to participate and see what's going on. If you have a question, I would ask that you pose it in the chat feature. If you've not used the chat feature, go ahead and look at that. If you click on your Zoom window, you'll see the chat feature down at the bottom with a little thought bubble or speaking bubble. Click on that and you can follow that. As you make your pitch, I will keep an eye on that channel and go to you. I'd love as much as we can for questions to be asked with video on. So when I call on you, activate your video and your audio. A neat little trick, if you're on a Mac or a PC, is that you can, as long as you're in the Zoom app, click on your space bar and that will activate your microphone. So overrides the mute function if you're on a Mac or a PC. Let me start by introducing our outstanding panelists. Ben Lopman is an infectious disease epidemiologist, a professor at Emory University's Rollins School of Public Health. His research focuses on vaccines and enteric viruses. I had to look that one up. Enteric viruses are viruses that are transmitted through poop. My guess is that the professor has been encouraging vigorous hand washing long before coronavirus. Prior to joining the Rollins faculty in 2016, Ben was with the Division of Viral Diseases at CDC, and he's spent a decade in London where he earned his master's and PhD at the London School of Hygiene and Tropical Medicine. He worked at UK's Health Protection Agency and did a postdoc at Imperial College London. In the last few months, he's redirected his entire Rollins team to focus on the epidemiology of COVID-19. So Willoughby Mariano is an investigative reporter at the Atlanta Journal-Constitution. Willow previously worked at the Orlando Sentinel and the Los Angeles Times. Her work has been recognized with a National Headliner Award in investigative journalism, the Atlanta Press Club's Award for Civil and Human Rights reporting, and an Asian American Journalists Association's Al Newharth Award. And she is currently president of the Atlanta chapter of the Asian American Journalists Association. In the AJC, Willow has been focused closely on understanding the statistics and data related to for Georgians. Andy Miller has been a healthcare journalist for the past 28 years as the CEO and editor of Georgia Health News. He's a double Duke grad, was a teacher and a basketball coach before being drawn to journalism at UNC Chapel Hill's J School, where I'll be teaching, fingers crossed, again in a few weeks. In 1985, he was hired by the Atlanta Journal-Constitution, where he had various editing and reporting positions before taking on the healthcare beat in '92. He's won all kinds of awards for his reporting on hospitals, state government, health insurers, and Georgia's mental hospitals. A decade ago, it seems just like yesterday, Andy launched Georgia Health News, a nonprofit journalism organization Georgia Health News has forged partnerships with a bunch of journalism organizations, more than 25. Though through Georgia Health News, Miller collaborates with organizations such as WebMD, NPR, HuffPost, ProPublica on investigative stories. He has a weekly radio show on NPR stations in Georgia. I should note that more than a week ago, we invited the Georgia Department of Public Health to participate in this town hall. The spokesman said, unfortunately, that no one at the agency was available due to scheduling conflicts. We're very sorry about that. Again, I promise we're going to allow time for audience questions. Pose your questions to everyone on the chat, and I'll do my best to work you in. If I know we're going to cover a topic related to your question later, and maybe a while before I call on you, be patient. Please, please keep your questions short and on point. This is not a session for speeches. So let's get on with deciphering the data. Let me go up here and see if I can share my screen again. All right. You should be seeing the PowerPoint slide there. You click forward on that. So let's start off a quick primer on what the state of Georgia's Department of Public Health publishes. The agency has a daily status report. This is a screen grab of today's. You can get it here. You can do a Google search and it'll almost take you straight to it. It's very, very easy. A lot of what we're talking about is going to be found here. Also on the site is an FAQ and a set of definitions. It runs 3 pages. It's easy to find at the top of the daily status report. Okay, with the next slide, I want to get the discussion going. It's the question I'm asked by family members and friends, and also when I post things to social media. Whose numbers should I believe? Allow me to illustrate. So these are the latest Georgia Public Health numbers, Georgia Department of Public Health numbers. The orange line on the screen, I think you should be able to see my mouse there, shows the 7-day average number of cases. For example, the numbers for June 18th are showing up there as 1,088 confirmed cases. And a 7-day moving average of 1,006. The preliminary data on the right side of the trend line seems to show a downward direction of the data. Here is the Johns Hopkins tracking data for Georgia published yesterday. It shows 1,263 new cases a day for June 20th. It shows dramatic upward movement. And here's the Atlanta Journal-Constitution's data for Georgia from yesterday, showing 1,706 newly reported cases and a 7-day rolling average of 1,336, another strong upward movement. It's even more confusing when you compare the specific days on the charts. So again, if you look at the 22nd of June on the Department of Public Health site, just 538 new cases, rolling average of 904. Johns Hopkins, 1,882 new cases, June 22nd, 3-day rolling average, 1,334. And the AJC, 1,073 new cases on June 22nd, 7-day rolling average, 1,227. Professor Lotman, you're a distinguished epidemiologist. Can you explain why these 3 respected institutions can't seem to agree on even the most basic facts?
Yes, it's a it's a terrific and fundamental question, and it seems at face value, crazy that there wouldn't be a simple metric, a simple way to know exactly where we are in this epidemic. I actually would start by saying, amongst us infectious disease epidemiologists, these people are commenting that there's an outbreak of armchair epidemiology going on. in that there are so many folks who are kind of interpreting data, who are trying to make sense of, in fact, of this kind of information. And I think the reason for that is that perhaps unlike models in physics, for example, this stuff seems pretty straightforward and interpretable. And in a sense it is, right? We just want a sort of time series here. We want a count of how many cases there are any given day. But it's so important to understand what goes into generating that data. And this is what we kind of obsess about in epidemiology, is sort of data generating process. So that's all a bit of pontificating and background without answering your question. I think fundamentally the reason that you see these differences comes down to dates and how you attribute dates. So there's a lot of different dates that go into producing, a sort of time series like that. That is a number of cases, occurring on a given day. There's, for example, the date that someone had the onset of their symptoms. There's the date that they sought care, so were first sort of seen by a doctor or some kind of healthcare services. There's the date they got tested, and then there's the date the case got reported. And so depending on which one of those you use to plot your data, you're going to see very different patterns. And probably the most useful thing for having your sort of finger on the pulse of where the epidemic is, you want to know how many cases were reported on a given day. And that's kind of what you see in the AJC and in the Hopkins data. The GDPH data is different. They're trying to reconstruct what actually happened in the epidemic. And in doing so, they use the dates that they use the kind of earliest of those dates that I mentioned. And that will give you a better picture of what actually is happening in the pandemic. But if you want to get a better sense of what's going on at any given time and what the trends are, the simplest metric is the number of cases reported in a given day, which is, again, is what AJC and Hopkins are reporting.
So in this particular circumstances, both sets, all three sets of data are useful, but we have to use them from different, for different purposes.
I think that's fair.
Historical perspective, what was going on, what's happening now, and how do we deal with the threat comes down to looking at the Hopkins and AJC data.
Yeah, that's right. That's right.
So Willoughby, where are you getting your data from? How are you presenting your data relating to the number of cases?
Well, so this is a very interesting question, because we, like a lot of other people, are using the State Department of Public Health information. And of course, as you noted, Richard, what we produce, can look a bit different than what the State Department of Public Health puts on its website. And the reason why we use what we use, the numbers that we use to create the visualizations of our data, is that we found that individuals, we were deluged with emails about people who were confused about how DPH was presenting its numbers. They got the impression that case numbers were going down dramatically based on that one DPH visualization that you presented, that graph, when in fact they were holding steady or maybe experiencing a slight decline, or as it is now, increasing in dramatic fashion. So, we figured that what people wanted to know was what is going on now with the virus, or at least very recently with the virus. And they want to see if it's, if more people are dying nowadays, if more people are catching the disease. And so we decided to present the data in a different way. We stuck to, just reported cases, newly reported cases per day here in the here in Georgia, because that is a way that that is very accessible to people. A lot of people are understanding it, you know, in that way, and not sort of it becomes more complicated to understand when you take into account the onset of symptoms, the date of actual, you know, the date of testing. So we decided to present the data in a way that our readers, you know, could more easily consume it.
Now, why did you choose the 7-day rolling average as opposed to the 3-day rolling average, for example, that Johns Hopkins has?
So there's one big problem with Georgia Department of Health data is that reporting of tests goes way down, or has historically gone way down over the weekends. So you can look at a day's number and you know, Saturday's number, and note that it's the newly reported cases are a lot lower than what they were on Friday or Thursday, and think, oh, hey, you know, cases are going down. Well, they're not. It's just that they're not being reported as you know, over the weekend all that well. So we needed a technique that allowed us to sort of smooth out those numbers. And again, they tell readers, give readers an accurate representation of trend lines, which is again what they want to know. They don't want to know that, you know, what, you know, that institutions or, you know, hospitals are not as, you know, not as ready to report on weekends as they are during weekdays. What they want to see is how the disease is progressing in Georgia.
Andy Miller, you've covered issues like these for decades, everything from AIDS to SARS to you name it. What are some of the issues that pop up in situations like this that you've seen previously that you're seeing repeated here?
Well, actually, Richard, I don't think I've covered anything like this. The impact of this pandemic and the length of it, and the I guess the density of information, and the actual weight on society and, you know, Georgia, America, the world is unprecedented. So on the numbers issue, I try to look at trends. I look at different websites to show me where the increases are, whether it's hospitalizations, whether it's new cases, deaths. I mean, all of these are important. And I try not to focus on specific numbers unless, because I know that, you know, as you've pointed out, there's different ways to present this data. But trying to look at trends, and clearly we're in a trend now where we're seeing pretty steep increases in the number of new cases being reported.
Now, if you listen to our president, he's repeatedly asserted that the reason these case numbers are going up is because more people are being tested. Dr. Lobman, how could we figure out whether that's an accurate assertion here in Georgia?
Yeah, that's you know, it's an easy assertion to make, but this is an empirical question. That is, we can answer it by looking at the data. And you know, there are clearly a couple of reasons that positive tests could be going up, either because there is a true increase in the incidence and the number of cases, or there's more testing, or both. You know, a pretty simple metric one could use to figure out if the increase is just a result of more testing is to look at the percent positive, not just the number of cases. And indeed, we see that in many of the states with increases, and especially those with dramatic increases like Florida, like Arizona, the percent positive is going up very quickly. In Georgia, it's a little bit less dramatic, but the percent positive has also increased.
Let's look at those numbers here in Georgia. See if I can do that there. I think you should be able to see, this is the rate of testing and positives from this morning from Johns Hopkins. Since Florida and Georgia appear next to each other on the page, I pulled both of those. The latest data from each on this site was the 22nd of June. So if we look at this, first of all, matches up with their other reporting on the number of new cases, but in Georgia, 8.9% percentage positive. And if you start breaking that out, June 10th, 5.3, June 21st, 22.7% positive, June 23rd, 7.5%. And the trend this week and last week is an increase in the number of positives, even as the number of tests goes up gradually over the week. As a professor looking at these specific numbers, what does this tell you?
Yeah, I mean, I think it's quite clear that the increase you're seeing is not a result of increased testing. The percent positive is increasing, and more to the point, I mean, I'm glad you showed the data from Florida here. Testing isn't increasing in Florida. It's been flat or even decreasing a little bit in recent weeks. You know, some other states, you've visualized a couple here, which I think are good representatives. California is one, for example, where there has been a pretty substantial increase in testing, I believe. And so maybe some of their increase is a result of increased testing, but you know, these percent positive increases makes it very clear that it's not just a matter of doing more testing.
The World Health Organization says it's a good goal to test sufficiently to keep the percentage below 5%. If you're testing and the number is less than 5%, you're testing enough folks. If the number of positives is more than 5, you have a problem, right? Isn't that the fundamental of their recommendation?
That is the recommendation. Yeah, I mean, there's of course there's no bright line, and it depends a lot on the state of your epidemic, but I think it's a good rule of thumb.
Now, for Georgians, this is potentially about to become a very important number if you are planning to go see relatives in the Northeast, for example, because we're right now just 1.1% below the testing threshold positive for quarantines to be imposed on Georgians, as has happened in South Carolina, Florida, North Carolina, Texas, going to the Northeast, with fines of up to $10,000 if you are found to have caused harm by being infected when you come. In addition, this number, I think there's probably some great value in publishing this number in a greater level of transparency, both at the state level and maybe for the AJC and others, because I think that there's some potential here for this to become an issue for us. In addition to the number of cases, what else is a good indicator for tracking the severity of the pandemic, Dr. Lotman? Hospitalizations?
Yeah, of course, hospitalizations are a good indicator. Probably the best single indicator is deaths, and the reason for that is, you know, there's much less kind of bias that can go either direction. You know when someone has died, and when someone has died with the virus that causes COVID.
Can I have you hold on that thought, because I want to come back to deaths a little bit later. It's going to screw up the PowerPoint. So let's hold that thought. Let's talk about hospitalizations, and we already have a question from Rusi Patel, who's asking, it seems the most useful data would be to have current hospitalizations on the website. Let me share the screen here again. This is from the GEMA website. This is their daily situation report. Andy Miller, is this a place you would go to get your hospitalization data?
Yeah, I think this is one of the only, if not the only place where we can see current patients in the hospital that have been diagnosed with COVID-19. I'm not sure it reflects those people in hospitals that are suspected of having it but haven't gotten a test result back yet. But this will give you a good indication of the fact that we're talking about people that are ill enough that they require hospital care. And that's, you know, that's being pretty sick.
So a couple of things here that I want to point out. Willow, I know you've been pulling longitudinal data for the paper. Where have you been getting that longitudinal data? Because when you look on this, there doesn't seem to be anything in this situation report that can give you longitudinal data. Where are you getting that?
We are looking at this data every single day and cobbling together, you know, and tracking, you know, each daily situation report. A lot of the longitudinal.
Let me highlight that, and so
Yes.
you can see it. So there it is down there. Current confirmed COVID-19 hospitalizations 1,000. It's sort of in tiny print at the bottom of the map. And then another useful metric, I suspect, is the number of critical care beds. Go ahead, Willow.
Yeah, and a lot of the longitudinal data, you know, the kind of data that would show trends and stuff, we have to kind of cobble together, since, you know, GEMA and the Department of Public Health have not, you know, put the data together in a way that I think, you know, readers would want. So yeah, but, you know, our data does come from public sources. We just have to hunt for them.
So let's look at this page. The change is, this is from the 22nd to the 24th, up 124 hospitalizations. And if you look at the number of critical care beds, it went from 30 to 25% available. So we've had just in a few days a 5% drop off in the number of beds. How does this help the public understand what's going on, Professor Loveman?
Yeah, well, you know, this is one of the real kind of concerns about this pandemic is the availability of healthcare services, and specifically hospitals and critical care beds and ventilator units to be able to respond, to have the capacity to treat patients. And, you know, we saw what happened in northern Italy when there was they had maybe the first large outbreak, at least in a high income country outside of China, and their health services in Lombardy were devastated, right? They were completely overwhelmed. And so this is a really important metric. Of course, it's not the only thing. It's, you know, again, we have to think about kind of what's generating the data and what's generating hospitalizations. Of course, that's first of all people becoming infected, becoming ill, and it's who gets infected. We know that there are very different kind of risks of having severe disease, requiring intensive care, requiring ventilator, based on age and other underlying health conditions. So it's not just about the numbers of cases that result in hospitalizations. It's who's getting infected, and again, there's some evidence that that's changing a little bit over the course of the epidemic now. Perhaps there's more young people being infected over the last couple of weeks. So, you know, this isn't a very important metric when, you know, interpreted with the case counts.
Rusi Patel, if you can unmute, you've got a couple of questions here buried in your question. Are you able to do that? Let's see if I can find you on the, yes, there you are. So
you've actually answered all of them, and I found that link at the bottom of this graphic you have is interesting, because the website kind of buries this data in a click here halfway down the page, and it's really hard to find. But y'all have actually answered my questions. I appreciate it.
Claire Gilbert, you have a question related to reporting requirements in hospitals. Can you ask your question? See if I can find it.
Hi, I was just wondering what the reporting requirements are. Like when hospitals, when anybody is required to report COVID-19 cases in Georgia, or is it all on a voluntary basis?
Anybody know the answer to that? Andy? Willow, go ahead.
They are required, and it's a federal requirement, and I forget which agency it is. It might be CDC, for hospitals and labs. The problem is that sometimes it can be a little chaotic, and reporting systems have needed some updating. But yeah, it is required. I mean, how well it gets done is a separate issue.
Any other questions related to hospitalizations?
If I could just make a comment on the point that Willoughby just made. These systems really do require updating. I think this is something that's been exposed by this epidemic and by the need for outfits like the AJC and Hopkins to pull these kind of data together. We just have outdated systems considering this is the 21st century. There's a dashboard, for example, from Germany. You can click on there's this online dashboard. You can click on any hospital throughout the whole country and see exactly what their capacity is and where they're at with relation to that capacity on a national scale. And we don't have anything like that. And I think it just speaks to how outdated some of our surveillance systems have become.
That's a scary prospect. Well, let's get back to deaths. Well, actually, let's look at one other thing first, and that is demographic information. There's here's the hospitalization rate that AJC has been tracking based on those numbers that you've been seeing. If you see the June 10th data, and then the rolling average of 805, and then there we are today. So it shows a clear trend upwards. It's interesting how the rolling average trails quite a long way behind the declining caseload, and then again trails behind on the increasing caseload quite a bit. I think that's quite interesting. Willow, any observations on that?
Just that it's alarming and was predicted. Obviously, and the predictions, for instance, by a Georgia Tech team submitted predictions that indicated to the state that such an increase would occur, and we might have problems with capacity, especially in a healthcare region, including Cobb County, Paulding, and Douglas. So I think that's an area we need to watch carefully.
And I was looking at the state's numbers, and the area around Athens also seems to be a little thin on the ground in terms of beds. Demographics and death rate. So this is the demographic data currently on the site. It's a little chilling for me to look at my age group and see that 25% of those who get COVID end up in the hospital, and a chilling number end up unfortunately deceased. So that's something that certainly scares the bejeebers out of me. But I don't find anything on the DPH site related to longitudinal data about how the epidemic is changing. Certainly we're hearing from some other states, for example, South Carolina and Florida, where it seems to be young people who are getting infected. How do we know, for example, Willow, the AJC's reporting yesterday on the number of new cases and their age. How were you able to find that data?
This is another case, again, where DPH's visualizations don't tell us and don't tell readers, I think, what we want to know, which are, again, trend lines over time. And so we have to go behind the data, and we have to go, not really behind the data, but we have to look at the website every day and track the numbers ourselves. You know, see what the COVID case demographics are today and figure out how they're, you know, for age group 40 to 49, you know, and compare it, you know, to the numbers that we collected a month ago or so to again, look at trend lines. You know, this is not work for the faint of heart. This is, it takes a lot of detailed work. You know, it takes a team, literally, at the AJC to just make sense of what DPH is providing.
And nobody's alleging here that DPH in any way is providing numbers that are false or fudged, but they have had some screw-ups that have caused embarrassment. Can you talk a little bit about that, Andy? You're still muted.
All right. Yeah. So the AJC has done some good reporting on some of the issues, the errors that the state website has presented. I'm reminded about how difficult this job is and how resource heavy this job is in terms of compiling all this information and getting it out there. Public health in our state has been traditionally underfunded and under-resourced, but there have been some cases of errors, and Willow can talk about that. And you know, people talking to me and to other reporters, I'm sure, saying, you know, this is really not presented in a reader-friendly way, and it's hard to decipher what's going on. I'm looking at, you know, I think that the 18 to 29-year-old issue is very important, and we did some reporting on that this week, and it's very, very significant to know what are the reasons behind that and what is the impact of that. And so, you know, basically, the state data it's not very transparent in terms of how they arrive at these numbers, and that's something that a lot of people have complained about.
So we've also, IVB3 has a question related to this. IVB3, if you want to unmute and identify yourself. IVB3, are you still there?
Sorry about that. Yeah, my name is Julie Edelson. And yeah, my question, I typed it in and then you started to head in that direction, so I appreciate it. It had to do with the earlier confusion, it seemed, where Georgia was reporting diagnostic testing along with antibody testing, which then had a big impact, obviously, on the positive or negative rates. So I just wanted to know, you know, if you could explain a little bit, if you know how that occurred, and whether, more importantly, has the problem been resolved, and can we rely on what we're seeing now in terms of testing numbers?
I can go into that.
Willow, go ahead.
Okay. So this antibody testing issue, which is, I believe, first reported in the Columbus, Georgia paper, they did a great job, you know, emerged after a series of nationally ridiculed flubs on how, you know, Georgia presented its data to make it look like which made it look like cases were declining, or perhaps, things weren't as, the problem wasn't severe as they were. And that raised a lot of trust issues with the public. And, but again, no one has written a story saying, hey, this was all intentional and meant to deceive the public. Now, to the antibody testing though, what had happened is that for whatever reason, and this has to do, I think, a lot with the systems created to report testing. The state was receiving reports of antibody tests, which show whether somebody has developed antibodies to the disease, and not actual, serological tests, which show whether or not somebody has the disease now. And they were clumping them together. So, which, was not really useful if somebody, again, is trying to track the course of the disease. And this problem, emerged at a time when Georgia was ramping up testing, and and the governor had made a commitment to do so because we had lagged far behind other states. So the, and so this did mess up our positive, our test, understanding of the tests, and, significantly so, because it was sort of, this wasn't just 1,000 tests or 2,000 tests. This was, lots and lots of thousands. And when you talk to health officials, they seemed genuinely surprised that these antibody tests had screwed up the numbers to the degree that they had. They did not realize that this number of antibody tests were taking place. Now, has this been resolved? That's a good question. Now the State Department of Public Health separates out those figures on its website. So that's a significant improvement. So I think the testing data is being reported in a much better way. And so you can look at the website and not necessarily see trend lines over time, but if you record the data like we do, to record every data point every single day, and crunch the numbers, you can see trend lines now.
So I promised Ben Lubman that I would allow him to talk about deaths by day in Georgia and why that was a big deal. Let me share the screen again. Let's look. This is an AJC visualization of the death rate in Georgia over time. Why is that such a big deal?
Yeah, well, first of all, I think that deaths are a good and clearly important indicator in the sense that, there are clearly other impacts, other health impacts of COVID, but death undeniably is the most severe. And it's something that it's also the most objective to measure, right? We sort of know quite clearly if someone has died and if it's a reported COVID death. So these patterns are, these numbers are very important for tracking the course of the epidemic in our state and nationally, globally. Deaths, however, are the worst indicator of the health outcomes of what's going on right now, right? And that's because of the sort of inherent delay times in deaths as well as other outcomes. So what do I mean by that? I mean that a person gets infected, they have, let's say, a 5-day incubation period, after which they start to show symptoms. Maybe it takes a week before their illness is severe and require hospitalization. And then on average, there's a gap of about 2 weeks, a lag of 2 weeks from hospitalization to death from COVID. So that means there's about a month from onset of symptoms to death on average for a case. So there's a real big delay in terms of where the epidemic is now and when we see that in deaths. We've seen cases creeping up. we've started to see hospitalizations follow that. And, you know, I would expect, based on that, that we may start to see an increase in deaths as well, because deaths is this lagging indicator.
So we should not take comfort in these latest numbers published on the AJC side of the declining trend.
I would say in a word, no, we shouldn't take comfort in it. You know, it would be a good thing, no doubt, if the case counts and the death counts start to diverge. It would mean we're getting better at treatment. It would mean that these steroid treatments, for example, are having an impact on mortality. But it's too early to make that kind of conclusion, for sure.
I would say, if I could add two things. One is, I think it's pretty clear, based on people I talk to, that we're doing a better job, we being the medical community, in terms of treating these patients, in terms of protocols, et cetera. The question I have for Ben is, how much of an undercount is there? How many deaths are being recorded as something else in our state and elsewhere that will actually cause COVID?
Andy, you're breaking up a little bit there. Could you repeat what you just said?
Yeah, two things was, one was, I think we are getting better in terms of the medical care provided to these patients. The healthcare system is doing a better job. They know what to do and what not to do in order to save lives. But the question then is, how much of an undercount is there that these numbers are not reflecting? That were actually caused by COVID, but the cause of death listed on a death certificate is something else.
Yeah, that's a
Go ahead, Ben.
okay. No, it's a terrific point, and very, very important one. And it's something that epidemiologists, people in my world, have been thinking about for many years, well before this pandemic. There's the same issue, for example, with influenza mortality. There's the same issue with the diseases that I work on, rotavirus, stomach bugs. They're just not very well reported because they're recorded because they're not always diagnosed. The information doesn't end up on a death certificate. So another measure that we use is so-called excess mortality. You can take kind of the baseline mortality rates based on historic figures and look at how much of a departure there has been. So what are the reasons that I'll say that this metric varies quite a bit from place to place, but overall there is more excess mortality than there are reported COVID deaths. So why could that be? Well, one is for the reason that you noted, that people are dying because of their coronavirus infections, but it's not being recorded as such. The other is that people are not getting standard medical services that they would have otherwise received had we not had a pandemic. So, you know, people are not going and seeking, you know, their elective procedures, or they can't get in for some reason. Resources are being diverted. I don't think it's possible at this point to tease apart those two. But, you know, in most places, and for example, in New York City, where the biggest impacts of this pandemic occurred in the US, there was really considerable excess mortality beyond reported deaths.
I have a question here from Clay Neely. Clay, would you like to ask your question? Unmute, please.
Yeah, in the message I mentioned that Ben said that death is a pretty inarguable statistic, but we've had cases where the cause of death has been disputed. Did they die because of COVID-19, or do they happen to have it when they died? And how long should it take for the physician or ME to sign off on the cause of death?
I don't know if Andy or Willoughby want to address that question.
Andy, you want to take a swipe at that? Are we getting a bunch of people, doctors, signing COVID-19 when they had COVID-19, but they were run over by a truck at in a parking lot?
Well, I think early on there was not as much testing, like back in February, early March, and the question to me is, if someone died of pneumonia in late February, would the death certificate say COVID in any way? And I suspect not. I suspect that there were plenty of deaths that were caught or hard to detect. There were plenty of deaths that early on may have been suspected as COVID, but they didn't get recorded because either the patient wasn't tested at the time or wasn't tested post-mortem. I'm told now that hospitals are testing post-mortem so that they have much more of a precise classification of the death. But I'm sure an untold number fell through the cracks early on in this pandemic.
Ben, any comment to that?
No, nothing much to add. I think that's exactly the issue. And I think, this is why we as epidemiologists often kind of try to zoom out and look at the overall numbers and overall trends. It's very, death certificate, cause of death reporting is really problematic. It's often very difficult to, look at death certificates. And that's, this is different than a kind of on an individual level, understand what caused, one person's death rather than sort of zooming out and looking at the statistics. And this is where, again, the kind of excess mortality data is a very useful indicator, because it doesn't rely on correct attribution of each individual death, because there can be many contributing factors.
Let's look to the future for a moment. I've been looking on the German websites and some other places, and a lot of places overseas, you see something called the R number show up. And Willow, the AJC does that data here in Georgia. This is from today, the transmission estimates in Georgia from your site. It shows the March 17th transmission rate of 4.1 and June 20th of 1.3. Why, first of all, how are you calculating this number, Willow? Where are you getting this data from? And what does it tell us?
Well, just wanted to know, John Perry, who is much more closely involved in number crunching, is also on this call, so he can chime in if he wants. But so what this is, how we came to calculate this number is that we looked at a variety of models that are well established and well regarded, and had different weaknesses and strengths. And again, chose one based on what we understood readers wanted to understand themselves, which is what is going on with the virus right now. And we chose a model out of Imperial College in London that was developed in 2013. That sort of, it's called sort of an instantaneous reproduction model. And what it does is it estimates the course, how many people on average are contracting, well, how many people on average, an individual gives the virus to, transmits the virus to. And we decided to use this one for a number of reasons. First of all, again, there's the so-called instantaneous factor. We can plug in to this model this complex series of calculations, the number of newly reported cases in a day, or over the course of 3 days, and have it spit out a particular day's average transmission rate, and do it with with reasonable accuracy. The other thing,
Ben, you were at Imperial back in those a little bit before that. Did you work on this this R number, coming up with this concept?
Yeah, well, I didn't come up with the concept. The concept has been around, well, in one form or another for about 100 years, actually. But we've gotten a lot better at measuring it, and one of the and estimating it. One of the groups that's done this is the Imperial College group that Willoughby mentioned. That's actually based on a technique that was developed by a colleague of mine at Emory. The kind of modern calculation of this was developed by someone named Peter Tunis, and it's a very nice metric, right? The R value basically tells you, like Willoughby was saying, what's happening in terms of transmission, right? So an R of 1 means essentially that things are stable. They could be stable at a very high level, or they could be stable at a low level, but they're stable. So there's all sorts of complications that go into it, but essentially that's the notion. Is like if R is stable, it's 1. If R is increasing, it's greater than 1, and if the cases are decreasing, R is less than 1.
So I think we've just lost Ben there. He just dropped off. So in the context here, that number 1.3 is showing increasing number of cases. Andy, Willow, are there questions that I did not ask you that I should have done?
Well, there are all sorts of questions. We talk about racial and ethnic impact. The disproportionate share of burden that is experienced by African Americans and Latinos here. I mean, that's something that there's going to be a lot of research on that, but that it needs to be a lot of research on that. So looking at the data, there's many different aspects of it that, are just very important. The testing numbers are alarming in the sense that we're seeing a higher percentage of positive tests. And right now we're seeing obviously an increase in cases, and we don't really know why that is. We suspect some things about it, but looking at the future, it will be very important to know what's going on there and how it's going to play out over the next few weeks.
Willow, what should I have asked you that I did not?
well, you did brilliantly, but actually I want to underline a point. And this is where I get a little pedantic as a journalist, but I think, one thread that is continued throughout our discussion is that we do need more transparency. The limitations of our data and our understanding of the data, are real. We are operating at a chaotic time with imperfect numbers, and we are doing the best we can as journalists. But one big sticking point, and one big problem we run into again and again is that we have questions to DPH about the numbers, and we want to give readers a more complete portrayal of how they're responding to this virus, and we are not capable of doing it because they've not let us in. And one analogy I've shared with you, I think yesterday as we were prepping for this, is that in any crisis, in a state of emergency here in Georgia and anywhere else, we are allowed to enter the Emergency Operations Center and watch how people make decisions, who is at the table, get a comprehensive understanding of what emergency response looks like. And, in this pandemic, we have not been given that permission. I think voters, readers, the general public are right to ask questions about it. And I think I feel my duty is to tell people more about this response, the quality of the response, and the decisions, and the, you know, what issues go into decision making, policy making. And we haven't been able to provide it. And that, to me, is sort of the most important core issues sort of behind these numbers that we're talking about. You know, these numbers influence policy, and we want to know how.
I echo those thoughts completely, because this has been an opaque process, and I can't think of a time when we need more information to make our own personal decisions and decisions, local governments, et cetera. We need more information. We need transparency, and unfortunately, there hasn't been any from the state public health department. I mean, we ask questions, and a lot of times we just don't get any answers.
Ben Lopman, why is it so important that the public trust data in a pandemic?
Yeah, thanks. And sorry I dropped off a moment ago. I mean, the data is really all we have to go on and to inform where we're at and what we need to do next. So it's, you know, it's the critical thing. I'm really grateful that AJC and other outfits are doing this kind of data-driven journalism around the pandemic. I think it's terrific. I also think it's a shame that they have to do some of these fundamental things that should be done by our state and federal agencies should be producing this kind of data. And so the places like the AJC could be reporting on top of it rather than doing these calculations themselves.
We are 2 minutes over, and I know there's several folks who had questions to ask, and we have run out of time. And I promised these folks that we would be done in an hour. But a big shout out to those who asked questions. A big shout out to Ken Foskett from the Georgia First Amendment Foundation. He's a board member there, and also the AJC investigations editor who had the vision for this town hall and did much of the heavy lifting of putting it together with pulling together this terrific group of panelists. Kathy Brister, who again provided wonderful logistical and copy editing support for us. Very much like to thank Andy Miller of Georgia Health News, Professor Ben Lopman from Emory Rollins School of Public Health, and Willoughby Mariano from the Atlanta Journal-Constitution. This video will be archived. It will be on the Georgia First Amendment Foundation website, probably by today or tomorrow. So if you think it's useful to share with others, please do so. And thank you all very much, everybody.